So dear friends, this parapharyngeal space is involved by a wide variety of benign and malignant neoplasms. So what is this parapharyngeal space? It was already explained in a previous class, the parapharyngeal space anatomy and also everything about the parapharyngeal abscess, its clinical features, then approaches, how to drain a parapharyngeal abscess, everything was explained in previous classes. So the link is given in the description box. Please see and study that. So today's class is for approaches to parapharyngeal space. How to access the parapharyngeal space for surgical removal of different types of tumors. Okay, so approaches to parapharyngeal space. Okay, so in majority of cases, these PPS tumors are originating from deep lobe parotid gland, or it can be, the most common is from the deep lobe parotid gland, or it can also be a neuroma or a paraganglioma arising from different nerves which are located in the retrostyloid compartment of the parapharyngeal space, or it can be a vascular lesions from the internal carotid artery. Okay, so the MRI is the investigation of choice, and we can know the exact location of the tumor by the displacement of the fat plane or the internal carotid artery displacement. By looking on the displacement of the fat or from the internal carotid artery, we can know from where this tumor is arising. It was also explained in detail in a class on parapharyngeal space anatomy. So the first and the main therapeutic option for any tumor in the parapharyngeal space is surgery. And the aim of surgery, like in all other cases, is complete excision along with a minimal morbidity. So complete excision along with minimal morbidity is the aim of surgery in a parapharyngeal space tumor. So I already told you there are different approaches. So how to decide to go with which approach? That depend upon mainly four reasons or 4 points. One is the decision to go or decision to select an approach is based upon, the one is tumor size, and the second one is superior extension to the skull base, up to which level the skull base is involved. Okay, the skull base extension. And the third is whether it is malignant or benign. Okay, benign or malignant. And fourth is the relation to major neurovascular structures. Okay, so major neurovascular structure relation. So depending upon these 4 main criteria, we decide on the approach to parapharyngeal space tumors. There are 3 main principles of surgery to parapharyngeal space tumors. One is a very good maintenance of preoperative as well as postoperative airway maintenance. Second is wide exposure of the tumor. And the third is gentle dissection along the tumor in order to prevent rupture. So the principles of surgery, one is airway assessment, second wide exposure, and the third gentle dissection around the tumor to prevent rupture. Okay, so we can divide these approaches into internal or intraoral approaches and external approaches. Okay, so intraoral approaches and external approaches. And external approaches are again mainly divided into 4 types. Approach can be internal, or it can be an external approach. Okay. You know that this parapharyngeal space is located, it is lateral to the tonsillar space and medial to the mandible. Okay. So I'll draw an head of the patient. Okay, so right. So the first and the most commonly used external approach is trans-cervical approach. Okay, it is a trans-cervical. Okay, so the first one is a trans-cervical. There are criteria for each one that I will explain. And another one is if we want to open the mandible to get a wide exposure, we can do a mandibulotomy, and that can be combined with either alone or it can be combined with a trans-cervical. So trans-cervical mandibulotomy approach. And the third one is if there is involvement of the superficial lobe parotid also, we do a parotidectomy incision along with the trans-cervical. So trans-cervical parotidectomy approach. Okay. Similar to the lacy S incision, we combine that with our cervical incision, right? So it is trans-cervical parotidectomy. Or if there is involvement of the skull base, we can combine with an intratemporal fossa approach, can be combined with a trans-cervical approach. Okay. If there is involvement of this area, then we combine it with a intratemporal fossa approach. So a combined infratemporal fossa with a trans-cervical. Okay. So these are the major or most commonly used external approaches for a parapharyngeal space. So and internally it can be an intraoral or it can be a transoral. So transoral or intraoral, or we can do a transoral robotic surgery, TORS. It's a recent advance and it is very getting very wide use nowadays. Okay, so transoral robotic surgery. TORS is usually asked as short note also. Okay, so transoral robotic surgery getting a wide acceptance nowadays. So these are the main approaches used for PPS tumors, both internal as well as external. So of this trans-cervical approach is the most commonly used approach. See this parapharyngeal space, it comes almost in this area. Okay, isn't it? So this is an inverted pyramid space located almost here. So through this trans-cervical approach, we can very well reach the inferior portion, tumors invading the inferior portion of the parapharyngeal space, isn't it? Through this trans-cervical, and trans-cervical is the most commonly used approach and very well reach the inferior portion of the parapharyngeal space. So which all tumors invade the inferior portion? One is tumor arising from the deep lobe of parotid. That is the commonest tumor in this inferior portion of PPS, and we can also reach the cranial nerves. Wide exposure of the cranial nerve, especially the hypoglossal, vagus and spinal accessory, can be attained through this approach, and also dissection of the parotid and also facial nerve. Okay, so and also facial artery. All these can be reached or exposed through this trans-cervical approach. So that is the commonest, most commonly used approach for a PPS tumor. And trans-cervical mandibulotomy. Trans-cervical, you can reach the inferior portion. If the superior portion of the PPS is involved, we need a mandibulotomy, isn't it? So for getting a wide exposure, or especially the superior part of the parapharyngeal space, we need a mandibulotomy, transmandibular, especially for recurrent and very large and also malignant tumors. Okay, so this approach is needed for recurrent, then large tumors or malignant tumors, if there is involvement of the mandible, in all these cases we have to go for a transmandibulectomy or a transcervical mandibulotomy approach is needed. Then the third one, and if there is involvement of the deep lower parotid gland, and if you need an extensive dissection of parotid along with facial nerve, then it is better to combine this transparotid transcervical incision or transparotid parotidectomy incision can be combined with a transcervical. Involvement of the deep lobe of parotid gland, and we need extensive dissection of the parotid along with the facial nerve. Go with a transcervical transparotid incision. And if there is involvement of the intracranial cavity along with the, or if it is paragangliomas or involvement of the post-styloid compartment of the PPS, we prefer and combine the infratemporal fossa with a transcervical approach. Infratemporal fossa with transcervical for intracranial extension, for involvement of the post-styloid compartment of the PPS, because we need a very extensive exposure to remove the entire lesion. Okay, so these are the 4 commonly used external approaches. And in the internal approaches, it is mainly a transoral. This transoral, oropharynx, uvula, anterior pillar, then tonsils. So actually we put an incision just anterior to the anterior pillar and go through that. That is in transoral. But the transoral approach is usually done for taking biopsy from a suspected parapharyngeal tumor, because the exposure is very much limited. If there is damage to any great vessels or any nerves, we cannot do anything. We will be in trouble. So very limited exposure, and also there is chance of rupture of this parapharyngeal tumor if we manipulate them. So this transoral approach is usually done for biopsy, taking biopsy, and if needed for excision, it has to be combined with an external approach. Okay, and through internal approach, this transoral robotic surgery is a better way, because we get in transoral robotic surgery we get a 3-dimensional approach. So better visualization of structures around the tumor, and also a very delicate and surgical removal of the tumor is possible. And so this is indicated, that TORS is indicated for parapharyngeal space tumors which are located anterior to the internal carotid artery. That too, for posterior lesions and retrostyloid lesions never go through an internal TORS. Even if it is robotic surgery, it should be limited to lesions anterior to the internal carotid artery. Okay, but there are advantages and also disadvantages for this TORS. The advantages are, there is no need of an external, there is no external scar. This disfiguring incisions are not put, so cosmetically very much appealing. And also a very accurate manipulation and dissection is possible. We can get a 3-dimensional picture of the whole process. Right? That is the advantage of TORS. There are also disadvantages. The main disadvantage is that this is technically very much challenging. Technically challenging and need training for all levels of surgical personnel. Starting from the technician up to the surgeon, it needs a very high level of training for the surgical, all surgical specialists or surgical personnel. Okay, all those who are standing in the operation theatre has to be trained. And it's a very delicate micro instruments, and they are very costly also. So that is a disadvantages. But for small lesions which involve or which occur anterior to the internal carotid artery, it is a better option is a TORS, transoral robotic surgery. Okay, so these are the approaches for PPS, and for easy remembrance, I'll write in a flow chart the scheme of approach I'll explain with a flow chart. So I already told you that the different types of tumors can happen in the parapharyngeal space, and the gold standard in the diagnosis of a tumor is a contrast enhanced MRI scan. So by doing an MRI scan, you found out that there is a parapharyngeal space tumor, and also look for the extension of the tumor and also the neighboring structures. First look at whether this tumor is in the pre-styloid compartment and is it accessible by a transoral approach, internal approach, the easiest method. Okay, whether accessible by transorally accessible. The answer can be yes or no. Okay, if it is yes, or it can be no, isn't it? So in both cases, next think of the purpose of surgery, whether it is a biopsy or whether it is a complete excision. That you have to think of. Biopsy or complete excision. Biopsy. Okay. In these cases, the next one you have to think like that. So first thing is think that whether the pre-styloid compartment is involved and whether it is accessible transorally. If it is yes, and if the purpose of surgery is biopsy, then what is the route? There is no doubt in that you can access it transorally. Transoral. Okay. Then, if it is no, and the purpose is biopsy, then what is the route? It is not accessible transorally, so you have to go with an external approach. It can be either a transcervical or it can be a combined transparotid, transcervical, or it can be a combined internal and external along with or without transoral. If you need, you can go externally as well as internally. But remember, for biopsy, you should not go with a mandibulotomy. Okay, so without mandibulotomy. Okay, so it can be a combined approach or an external approach alone. But for biopsy purpose, don't go with a mandibular excision. Right? So that is for biopsy purpose. And again, the complete excision can be for two types of lesions. One, it can be a benign lesion or it can be a malignant. For this also, it can be malignant or it can be a benign. And if this benign lesion is limited to the pre-styloid compartment without approaching to the deep lobe of parotid, that is independent of the deep lobe of parotid, it is not arising from the deep lobe of parotid gland. Okay, then you can very well go with the transoral approach. And again, for not accessible transorally but benign, and again you can go with the same approach, that is transcervical or transcervical transparotid with or without an internal combination and without mandibulectomy. Okay, so for both cases this will be the surgical approach. And what about malignant lesion? Whether it is approachable transorally or not approachable transorally. So malignant, if it is approachable by transorally, there will be an extensive extension into transoral space, oral cavity oropharyngeal structures, or it will be located high in the parapharyngeal space. So in both cases, you have to go with an external approach plus mandibulectomy. Okay, so this is the scheme of approach to parapharyngeal space. So I'll explain once more. First, think of whether there is a pre-styloid compartment involvement and whether it is accessible transorally. If the answer is yes, think of the purpose of removal. Whether it is for biopsy, go with the transoral approach. Whether it is complete excision. If their purpose is complete excision, then again think whether it is benign or it is malignant. If it is benign and it is involving the pre-styloid compartment only and independent of the deep lobe of parotid gland, then it is better to go with the transoral approach. If it is malignant, then you have to, and also if it is there is extension to the oral cavity or oropharynx, or if it is located high in the parapharyngeal space, then go with an external approach, whether it can be a transcervical or a combined transcervical transparotid or infratemporal fossa, or it can be a mandibulotomy. In either way, go with that. And if it is not accessible by a transoral approach and the purpose is biopsy, then go with an external approach but without mandibulotomy. And even for benign lesions, the same is applicable. You can approach it without a transmandibular approach. And again, if it is not accessible transorally and it is malignant or high in the parapharyngeal space, go with an external approach with a mandibulotomy. Okay, so the external approaches, the complications are more. And all the complications of parotidectomy, all the complications of mandibulotomy, infratemporal fossa approach, all you can write. And transcervical transparotidectomy, mainly the wound infection, seroma formation, cranial nerve palsies, the first bite syndrome, Phrase syndrome. Again, the first bite syndrome and Phrase syndrome are usual short notes. Okay, so prepare that. So to summarize, I explained about the different approaches, mainly the internal, that is transoral or intraoral and transoral robotic surgery. I explained the advantages and disadvantages of each, and also the external approach can be a transcervical or transmandibulotomy, transparotid or infratemporal fossa combined with all these. And this is the scheme of criteria for selection of an approach for a parapharyngeal tumor. Thank you.